We're going to get started. We hope you're all here for launching anti-racism clinical skills into simulation space. My name is Elise Everett, and I am the level director of clinical clerkships at the University of Vermont. I'm also a UMEC member and chair of APGO FDS. So you intermittently see me in that role, I should say. And I'm going to ask my counterparts to introduce themselves.
Hi, Kate Nicholas. I'm the Director of Simulation Education and Operations at the University of Vermont.
I'm Helen Gandler. I'm an MS3 at the Larner College of Medicine at the University of Vermont.
And Wanda, we'd love you to introduce yourself.
Hi, I'm Wanda Countess, and I am an SP. Thank you.
Excellent. All right. So none of us have any disclosures. And our goal for today is we're going to start thinking about how we might develop an anti-racist curricula for learners in the medical field. So some objectives we have for this morning is to identify behaviors that demonstrate anti-racism clinical skills. We're going to take one of the APGO milestone 1 cases, and we're going to intercalate into that case an anti-racist clinical skills exam, or create an anti-racist clinical skills exam from that. And we're going to think about the behaviors that one does to perform anti-racist clinical skills. And we're going to utilize simulation with standardized patient of color to allow learners to handle some classic OB-GYN scenarios.
All right, so the reason we are here in this particular workshop is because racism is deeply rooted in medicine. Some scholars date the origin of scientific racism back to 1735, when Systema Naturae by Carl Linnaeus established a 4-tier hierarchy of race with white people at the top and Black people at the bottom. And physicians supported the creation of this hierarchy because it allowed white people to sustain and justify social and political power. As of August 2021, 209 declarations of racism as a public health crisis have passed in 37 states, with about 200 of these passing after the murder of George Floyd in May of 2020. Physicians today want to believe that we are part of the solution and not part of the problem. However, clinicians are taught to pay attention to race through guidelines and clinical prediction rules that employ race as a biological construct. And we are taught through observational studies that report on racial health inequities without providing the important socio-political framework for these outcomes based on race. And by treating our patients based purely on what we have learned about health outcomes between races and not based on the individual patient's unique background and experiences, we fall into the trap of using biases, whether that's intentional or not. The explicit and implicit biases of physicians are shown in the SNAP associations we make about individuals based on either a past experience or because of limited information and exposure. And these biases can be incredibly harmful by leading to a cycle of using stereotypes to structure our patient encounters and clinical decisions. These stereotypes are often come in the form of dominant narratives, which are explanations that are told in service of the dominant social group's interests and ideologies. So for example, one dominant narrative is that patients who miss appointments don't care about their health, which is an assumption that allows the physician to dismiss or deprioritize the needs of a patient who might be struggling to make their appointments. And some physicians will say, well, this doesn't apply to me because I'm not a racist, I don't adhere to dominant narratives. But we would argue that the countless studies and reports of patients of color receiving different treatment from their white counterparts demonstrates that a physician who practices without any bias whatsoever is more likely to be the exception to the rule. But therefore, it's not enough for us to label ourselves as not racist and move on. And to quote Ibram-X. Kendi, one either allows racial inequities to persevere as a racist or confronts racial inequities as an anti-racist. There is no in-between safe space of not racist. So today we're going to make an effort to confront racial inequities and make some changes. So I just talked about dominant narratives and how they can manifest in the clinical environment. I'm going to introduce some other examples of dominant narratives and 8 anti-racist clinical skills, or ARCs as we nickname them, that a physician can use to counter these dominant narratives. The first dominant narrative is the example I posed before, that a patient who misses appointments doesn't care about their health. An anti-racist clinical skill that could be used to counter this dominant narrative is to generate alternative hypotheses. This means identifying and challenging the label that drives your bias, then identifying the real structural forces at play. And so maybe you ask yourself, what else could be going on for this patient in this scenario? Another common dominant narrative is that the lifestyles of people in certain communities lead to poor health outcomes for those people. The response to that dominant narrative could be to partner with the patient by considering a position that sees the patient as inherently invested in their health and well-being, and approaching the clinical encounter from a place of partnership and not antagonism. Next dominant narrative is that fibroids are common in Black women and chronic pain is to be expected for these patients. And in this case, the physician could personalize the patient, which means reducing the impact of an identified implicit bias within yourself triggered by the patient's name, their socioeconomic status, and or their race, whether that's identified by themselves or presumed. Another common dominant narrative is that patients who complain about care are disruptive or angry. A clinical skill here is to reframe a patient and call attention to the structural drivers of their actions in the clinical encounter. A dangerous prevalent dominant narrative is that Black patients have a higher threshold for pain. There are a couple of anti-racist skills that could be employed here. One is to question scientific racism, and this means to not accept the association between the assumed race and a medical diagnosis, and instead to consider a more detailed family and ancestral history of your patient. Another is to deconstruct the dominant narrative by taking the time to recognize your own potential biases and be aware of the impact of the bias throughout the encounter. The last dominant narrative I will introduce is that patients who refuse medical care don't want to get well. Again, there are a couple of anti-racist clinical skills that can be used to counter this narrative. One is to utilize complexity thinking by considering the innumerable reasons why a patient may not think your particular choice is the best option for themselves. And another skill is to decenter the clinician and center the patient by intentionally creating a space for the patient to voice their concerns.
Great. Thanks, Helen. So we just want to talk briefly about the Milestone 1 curriculum because not everybody may be familiar with it, but it's a case-based curriculum for Milestone 1, which is, of course, the sort of competencies and skill sets that we expect a day 1 intern to arrive into residency with. And it was created by APGO and the UMEC committee. The target population for that curriculum is post-clerkship students who are transitioning from the 4th year into the intern year in an OB-GYN residency. That said, it can certainly be used for multiple levels of learners. It is linked or mapped to the ACGME competencies or ACGME milestones, and also linked to the entrustable professional activities. And so it allows you to make some lesson plans or teaching activities, again, for multiple levels of learners, and to link it back to these frameworks. There are 5 Milestone 1 cases, and they cover outpatient and inpatient OB-GYN topics. And so we chose this as our framework, as our sort of basis for building in these anti-racist clinical skills.
So here I laid out the basic steps of our project. The first step was working with Dr. Nicholas to adapt the Milestone 1 cases that Dr. Everett just talked about into stations for a clinical skills exam that we could realistically run at our institution in Vermont. So in the process of designing the CSE, we realized the potential that this CSE has had to incorporate anti-racism into our curriculum. Dr. Nicholas shared with me a textbook called the Textbook of Physical Diagnosis, History and Examination. And in its most recent edition, it has a chapter on deconstructing racism and bias in clinical medicine. So I use this chapter as a basis for outlining the 8 anti-racist clinical skills that I introduced previously. And my thought process here was that all of the skills that we expect learners to master during either medical school or residency are organized and coded so that teachers or mentors can use a grading rubric to check off each skill as mastered. So why not organize and code a list of anti-racist clinical skills to be graded on? We worked with an SP of color and other collaborators to design a CSE station that would provide learners the opportunity to work with standardized patients in a low-risk setting to demonstrate and practice their skills in anti-racism. So our next step is where this group comes in. In order to create a proper assessment for the mastery of these anti-racist clinical skills, we need your help to identify what anti-racist behaviors, actions, phrases demonstrate particular anti-racist clinical skills.
Great. So I know I preemptively sent you to your breakout rooms, and I apologize for that. I was being proactive, and I'm really enjoying this power I have to send people into cyberspace and bring them back as the commander of the space shuttle. So we have a small group, and so we're only going to look at ARC 1 and ARC 4 and ARC 8. And so you're going to go into a small group of 2 or 3 of you. And I actually assigned Dr. Nicholas and Helen Gandler into 2 of those rooms. And then I will pop into the 3rd room just to make sure that you're on track. And what you're going to do is collaborate with your members in your breakout group about your particular ARC. So if you have ARC 1, that's generate alternative hypotheses. And so I want you to make a list of phrases that the learner might say, verbal things, nonverbal things, clinical skills that they might do, things that you can observe that would demonstrate that they were using the ARC, that they were generating alternative hypotheses. And so we've provided you with a worksheet, which we'll show in just a second. And then someone in your group should be the scribe to sort of write things down. And that same person can be the one that will share with the larger group. So next slide, Helen. So this is the worksheet that you can work off of. So if you want to take a picture, that's maybe the simplest way, is just to take a picture of the screen with your phone. And then at the top, when you get assigned to your room, you can just put your ARC there. So if you're ARC 1, you just put generate alternative hypotheses. And then again, you want to write here things that somebody who's assessing the CSE can see or hear. So behaviors, knowledge, clinical skills, verbal, nonverbal communication, those kinds of things that would demonstrate that particular ARC. And then the next slide, again, if you want to use your cameras, you can take a photo. These are the various ARCs. I've also put it at the top, so when you go into your breakout room, it should have the title there, so you know which breakout room you're in. So again, ARC 1 is generate alternative hypotheses. And then you're going to go to 4, which one of you is going to be in group 4, which is utilize complexity thinking. And then 8 is framing. So it looks like I saw some cameras out. Everybody had the opportunity to take a photo of those 2. Okay, next slide. Or is this time for me? Do I get to hit the button now?
You get to hit the button now. The next time we all regroup.
So I'm going to hit the button, and then it's going to, I think you get to choose to go, or you can say not now. So now is the time to go. So go. And then if you get lost or something, then you can always leave and come back to this main room. And we're gonna give you, so it said 20 minutes, it's 11:30 now. Does that still work for my team? I think maybe we'll cut it to 15 since you're in small groups. So I will bring you back at 11:45 to the group. Okay, I'm going to hit send now. So, all right, I think I just hit join, right? Arcs one, yes. Oh, I don't want to join it. How do I send everybody? Oh, okay, let's see. I don't want to close. All right, I'm going to hit join. Let's see what happens.
Oh, I see. At this point, everyone can join the breakout room that they've been assigned to by hitting more breakout rooms, and then it should bring out a list or an option to join your breakout room. I'll wait here until everyone's gone to make sure that everyone's got it.
It went missing. I had it up and then it went away again.
Do you still have the option for more?
No,
on
no,
your
it didn't
Zoom?
say that anymore down there.
I know. I know. Whew. All right, I'm feeling better as I see all
Yeah.
these faces coming back from cyberspace. I did not lose any spacemen or spacewomen in our journey.
Your
Okay,
button control
Ellen,
was
do you
good.
have the slide deck to share again? So what I'd like to do is we're just going to hear from each of your groups. And since we're such a small group, why don't whoever's your presenter just kind of summarize your discussion and share some of the phrases and observations that you think could be added to an assessment tool for a clinical skills exam around anti-racist clinical skills. So who wants to, ARC 1, we're going to start at the beginning. ARC 1, who was ARC 1, which is generate alternative hypotheses?
So hi, I'm Cassie Carberry. I was with Brianna and Kate, and we talked about ARC 1. I think importantly, we figured out that it's not that easy to come up with scenarios where, especially in a standardized patient interaction, that you could demonstrate this particular skill. But some of the things we talked about is, ideas like chronic lateness to appointments or not being able to come to your appointments, as well as maybe not adhering to a treatment regimen in the way that your doctor might want to. Those are opportunities where we can discuss that with the patient and realize that it may not be, those things may be happening not for the reasons that we assume. And so the things that we came up with were, just very directly having an empathetic conversation with the patient about why those different things might be happening, and trying to offer them some help in changing and breaking down the barriers to whatever that may be.
Great. So I heard expressing curiosity. So asking why, I've noticed you've been, haven't shown up at the time of your visit for the last 5 visits. I'm wondering what's going on with you. Can I help you in some way? Would a different time of day work better for you? Those kinds of things. Great. Okay. So
Can I just add one quick thing, Elise?
yes.
Because I wanted to add in a comment that Brianna made when we were talking about someone maybe not doing what it is you asked them to do. In addition to saying, so let's review what we talked about. Did you have any questions about it? She asked the question, which was, what else are you doing? Because maybe somebody's doing something differently that's working for them other than what you recommended. So I just thought that was really kind of pushing past, maybe the patient knows something I don't. So that was really great insight. Thank you, Brianna.
Yeah, that's great. Awesome. Okay, ARC 4, which is utilize complexity thinking. So anyone who's sharing from that group?
I will be sharing. So my name's Corby. I'm a medical student here at the University of Iowa, but we talked about several things. And basically for our ARC, we thought of a scenario in which you were like doing shared decision making with the patient and there was like a disagreement there. And so we came up with the ideas that like students could use in an OSCE, for examples, would be like using open-ended questions to kind of get at why the patient it doesn't like the plan that was put forth by maybe the student or whoever it was. And then also trying to use like non-judgmental phrases too when you're asking those questions, and you're not trying to like assume anything when you are asking those questions. And then the other thing is maybe putting like a little bit of, or something that you could look for also on that student is like nonverbal cues. One example we thought of was not hesitating after you've had a disagreement maybe with the patient, to give the patient some time to like reflect with what they were disagreeing with, and then also maybe giving them time to explain why they disagreed with whatever they were disagreeing with. So those were some of our ideas.
Great, excellent. Any other comments from members of that group? That's great. I heard, if we see the student doing shared decision making, that would be signs of this complexity thinking. If we, heard the student looking for the patient's, ideas as to what would work for them and what wouldn't, or soliciting that from the patient, would all be observable behaviors in that setting. Okay, ARC 8, framing. Reframe a patient to call attention to the structural drivers of an observed health outcome or to counter dominant narratives. Who is the presenter? Rashmi.
Yes, thanks for picking me. Anyways, I had the pleasure of working with Sheena, and I think I said her name right. So we're working on the dominant narrative actually of a situation like where a patient comes in and they don't agree with your plan for, let's say, induction for postdatism, and especially in our immigrant population, sometimes they rely very heavily on their natural cycles rather than on ultrasounds for dating their pregnancy, and they may not agree with the plan for induction, and how a student might handle that situation, and what kind of assessments you could use that haven't already been mentioned. That's the trouble with going last. So a lot of the good stuff has been said already, but just perhaps I might add on body language. I think watching the nonverbal cues, as this young gentleman Corby had just said, where a student might be sitting, with his arms crossed like this and far away, a standoffish kind of an appearance, versus leaning forward, versus maintaining eye contact and being at the same level as the patient, being respectful of what the patient is saying. So these things about body language are very important, and you could assess perhaps how good a listener the student is, and in listening to what the patient is saying and not being dismissive of what the patient is requesting, even though it may not agree with what our recommendations may be, and how to handle disagreement in a very respectful way. And another was does the student offer alternatives? Maybe our way isn't the only way, and we should be offering alternatives, which they are feasible, may not be our only recommendation, but at least allowing the patient to express themselves and their interest, and being helpful to kind of get to a common place in a safe way.
Yeah, great. And the only thing I would add, as I was thinking about this, and it's actually Brianna made me think about it, is also just asking the patient what their understanding is, because sometimes we assume that the patient understands, and that when they then don't do what we say, it's because they don't agree with it. When it could be that when they don't do what we say, it's because they don't understand what we want them to do. So also asking for the patient to sort of that read back would be a good tool as well. Okay, next slide, Helen. All right, so now what we're going to do is we're going to have Dr. Kate Nicholas and our SP, Wanda Countess, are going to do an SP encounter for 10 minutes. And they're going to try to demonstrate an anti-racist SP clinical skills encounter. And so as the audience, I want you to be a really active listening audience and try and note down when you see behaviors, either verbal or nonverbal, that demonstrate either the arc that you were assigned or any arc, since we're in such a small group. Or if you see a moment when Dr. Nicholas maybe missed an opportunity where they could have done one of the arcs.
So Kate's task, or Dr. Nicholas's task, will be to take a history from the patient and counsel the patient regarding her request for a mammogram.
All righty, so here's my case. Monica Jones is a 29-year-old cisgender woman who was interested in a referral for a baseline screening mammogram because a colleague at work was recently diagnosed with breast cancer. Monica was seen in the office 6 months ago for a routine annual exam, and all exams and tests were normal. I just want to point out that anything that is in red is what changes we made from the original milestone case to make it work for this purpose. Okay, can I have the next slide, Helen? So this is our patient's history. Her personal medical history: diabetes. She had 1 C-section. Her obstetrical history: 1 spontaneous vaginal delivery without medical assistance, 1 C-section, 1 scheduled induction, and then a spontaneous vaginal delivery at 27 weeks. 4 pregnancies, 3 children. That last pregnancy was complicated by diet control, gestational diabetes, no allergies, no current medications. She identifies as cisgender. Her pronouns are she, her, hers. Her self-identified racial identity is African American, and her family is African American and Asian. She's a smoker. She's divorced. She works at a bar. Family history: diabetes, high blood pressure, heart disease, gout, arthritis, chronic heart failure, obesity. No malignancies, no breast cancer. And she had her PAP 6 months ago. Everything was normal. Nothing else was worrisome. 5 lifetime sexual partners, only been sexually partnered with men, a new partner in the last 3 months, and does not always use protection. She's currently in good health. Her BMI is 31.
And just to note that the milestone 1 case, the original is in black, and then the red is sort of what we did as a group to try and elicit some of these behaviors so that we could, try and assess anti-racist clinical skills.
All right, so I'm gonna invite my patient. I think it might be helpful. Well, you all can stay on, I think. We were gonna have you turn off your videos, but I think it's okay for you to stay on. All righty. Good morning, Ms. Jones. May I call you? How would you like me to refer to you?
You can call me Monica.
Hi, Monica. Good morning. My name is Dr. Nicholas, and I'm going to be seeing you today. So can you tell me what we can do for you today?
I want a mammogram.
Okay. So can you give me a little bit more information? What's happening for you that is starting that request?
Well, I'm having these problems in my right breast. It feels funny, so I want a mammogram.
Okay. Okay. So we saw you about 6 months ago. Your doctor saw you 6 months ago. So, and at that time that breast exam was normal.
Yes.
Okay. I'm going to ask you a few questions, if that's okay. Are you having, you said it feels funny. Can you talk a little bit more about that? What feels funny?
I can't really put my hand on it, but it just feels funny. Like when I lift my arm, if I'm doing something or turn a certain way, it feels funny.
Okay. How long has that been going on for?
It's been going on about 2 weeks now.
About 2 weeks. Okay.
Yeah.
And can you tell me where you are in your cycle, when your first day of your last period was?
My last period was last month sometime.
Last month. Okay.
Yes.
Are you late for a period?
No.
No. Okay. All righty. So a few more questions for you. Have you noticed any changes to, is it one breast, both breasts? Sorry,
It's my right breast.
right breast. Have you noticed any changes to that breast at all? And by that, I mean, any skin changes, any rash on the breast?
No,
Any kind of puckering or indentations?
no,
Any discharge from your nipple that's not normal for you?
no,
Has the nipple position changed? Positions
No.
like it was inverted, now it's extra, okay. Now you said it was when you lifted your arm, and I understand from looking at your record, you're a bartender. Do you do a lot of lifting with that work?
no more than normal.
Okay.
I've been doing this for a while.
Okay, do you feel like you could have pulled a muscle in that area?
No,
No, okay. And I saw that you've never had any breast cancer, a lump, no biopsies, and no breast cancer in your family.
no,
Okay,
no.
all righty. So, so a mammogram would not be the first thing that I would do here.
But it's the first thing I want done.
I understand that very clearly. Can you tell me why it's the first thing that you'd like done?
Well, because I have a girlfriend that works with me. She has breast cancer.
Oh, okay.
And I'm sure that I'm okay. So I want a mammogram.
Okay. Can you, so one of the reasons why I would say that a mammogram would not be the first thing I would do, one has to do with, you have no history of breast cancer, no previous any cancers of your own, you're 38. It would not be, that wouldn't be the first thing I would do. I might instead recommend that you come in, we do another breast exam, and then potentially get another opinion from someone, maybe an ultrasound of the area that's bothering you. I just don't know if a mammogram is necessarily going to give you the reassurance that you're looking for. How old is your friend, by the way?
We're the same age.
So
We're the
she's
same-
also,
We're the same age. We have the same physical, basically, makeup. We have some of the same economic issues. She told her doctor that she was having problems with her, excuse me, with her breast. And immediately her doctor gave her a prescription to get a mammogram. First of all, you're not my doctor.
I know.
And I think my doctor would have given me this, but maybe you're not giving me this. Her doctor did it right away. She is white. And I don't understand why you are not allowing me to have a mammogram.
Okay. All right. Well, thank you for sharing that. I'm hoping that there's nothing in my behavior that is telling you the reason I'm not doing this is because you're a person of color.
She didn't go through all this. She asked for a mammogram and her doctor gave it to her.
Yeah. I can understand your, I think I can understand where you're coming from. I don't know what went on between her and her physician, and I don't know anything about her history at all that would have made them do that.
She told me that she just told them that she wasn't feeling right. They gave her a mammogram. She has breast cancer. I
Right.
don't want breast cancer.
Right. No. I don't want you to have breast cancer either. I'm actually not quite sure what to do here. And I'm wondering, would it be better? Okay. Would it be better for you to speak with your own physician about this? As
But maybe-
opposed to,
Maybe I should speak to him.
yeah. Okay. So what I'm going to do, if it's okay with you, is I would like to, I'll obviously make some notes in the chart, but I'd like to have a conversation with her as well. Would that be okay with you? Or would you rather you have that fresh conversation with her?
I'd rather have that conversation because I
Okay.
just don't understand why you just can't give me the prescription if I'm having problems.
Right. No,
And
I can understand why you don't understand it. I'm just thinking that it's not going to give us the reassurance that you might be looking for. Although, I'm sorry, that's the reassurance you're looking for. So I think what we'll do is I'll make a note in the chart and I will make sure that she gets back to you as soon as possible, because I don't want you to have to wait any longer or be worried about this.
But now I'm going to wait because I couldn't get an appointment with her. This is why they gave me you,
Right,
and I'm still waiting.
right. I hear you. I just don't feel like it's the right thing to do. I don't know how to reconcile what you want and what I think is the right thing to do.
Well, the right thing to do is to just give me a prescription so I can go have a mammogram.
So what would happen for you if you do have health insurance? I think I saw that. What would happen if they didn't pay for it? Would you be willing to pick up the tab on that?
Well, why wouldn't they pay for it? Because we work at the same place and we have the same insurance.
And hers got paid for.
Yes.
Okay. All right. I think I'm going to leave it at this right now, and I will make sure that your doctor gets back to you as soon as possible. And I'm sorry. And I'm sorry.
You just wasted my time.
I'm sorry. And thank you. Everybody take a breath. No, I want to thank Wanda for hopefully giving us something to work with here in terms of the kind of things that we talked about. I just want to check in with Wanda. Any thoughts that you want to share with us before we have a conversation with the rest of the group?
No, but I could understand the patient just feeling left out in limbo,
Yeah.
with nowhere to go.
Yeah. Yeah.
Not knowing when she's going to see have another appointment, especially with what's going on today. And then also in her mind, she thinks that there's something wrong,
Yeah.
which could just take her down another path.
Right. Thank you for that. I just want to also let you know, Wanda was very instrumental in helping us put this case together. So a true co-collaborator here.
Excellent.
All right, should we turn it over to the group?
Yeah, so we'd love to hear from all of you. First of all, just kind of maybe give if you saw some of the ARCs being used. Anyone want to say that they saw an ARC and what they saw? If not, I have one ready to go. So I saw ARC 5, which is decenter the clinician and center the patient. So create a space for the patient to voice their concerns. So I think multiple times Dr. Nicholas kind of asked Wanda for her thoughts in terms of what was going on with her, why was she interested in a mammogram, those kinds of things. And others, I saw another one as well. I saw ARC number 7, which is partnering with the patient. So multiple times, Kate, I would say maybe Wanda didn't buy into the partnership, but Kate did occasionally, or Dr. Nicholas did offer a couple of opportunities to partner with the patient. So suggesting, to have an in-person exam as a starting point or sort of a compromise. So there were some efforts made there. Excellent. So
I would
yeah,
just
go
ask
ahead.
people for any other observations. They don't have to be connected directly to an ARC, because we're all still, kind of get used to them. But any other observations about nonverbals? Was there anything there you noticed that was particularly helpful, not helpful? It's hard to do on this setting, but I tried to give you a couple.
I think that, yeah, it is a little tough to go back to the ARCs right off the hop.
Yes, it is.
Elise
Yeah.
seems to have them memorized. So I'm trying to read through that thing to see what I would say that would fit your answer there, Elise. But yeah, thank you for just opening it up a little bit. But I thought you did a really good job trying to understand what her concern was. And I think you got it. It's just you didn't agree with it.
Right.
And I think that you kind of held your ground and you tried to offer her alternatives to her care. You know, you wanted to invite her in for a breast exam. You wanted to invite her in for an ultrasound perhaps, and try and explain and rationalize your kind of viewpoint on the issue. In the end, I'm not sure that a happy place could have been found between the two of you. And I think that it's really important to offer that alternative of a second opinion. You know, if you don't like what I'm saying and I'm not your physician, then let's just write it into your chart like you suggested. So I think that asking the reason why is very important. Why is it that you're worried about a mammogram? And then you understood why she was asking for this, because her friend had had a diagnosis of breast cancer, you know, off of one mammogram. So I thought that this is a very real situation and happens routinely, you know, in our, not routinely, but often in our offices. And I think you demonstrated many good approaches, despite having the stubbornness of the patient asking for the same thing again and again.
Yeah.
There was a comment in the chat from Dr. Abbott who had to leave, but she said she wasn't convinced that this scenario would allow students to identify the cause of the physician's reluctance. So I think it brings up a good point of, you know, after a scenario like this, that debriefing is important. And, you know, in order to make this happen, I think the student would have to know sort of what the recommendations are for mammogram. And that's where the reluctance come from, is because there's a request that is really outside of the current recommendations for mammography. And some students will know that and others will not. Other thoughts
I think that's
about?
I think that's where it's really important to set the groundwork before the simulation, so that they know that they're focusing on the ARCs and not necessarily on the medical management of why a mammogram is not indicated or indicated.
Yep.
I do think that, you know, I'm trying to imagine if this was a real scenario and the patient was coming forward, if like fairly early on in the conversation, when the mammogram, getting the mammogram or not getting the mammogram comes up, if she immediately feels like she's being dismissed and she already has that in her mind as possibly because of racism, that it's very hard. I mean, I think grappling with that and maybe talking about that a little bit more. And if the patient was even willing to say that, which I think a lot of times that wouldn't happen, that maybe there could have been a little bit more exploration. I think you did a great job, Kate. Like you said, I hope that I'm not doing that, but I think that even validating and saying, like, you know, that's fair. Like, that happens. We know that care is very disparate, you know, and also maybe like focusing on like how the problem can be addressed and making sure the patient understands that you're concerned about it. You know what I mean?
Yeah, no, I think that's a really great idea, because, you know, Wanda put that out, and my response, I don't know if you saw that, was to do this, like, whoa, right? Like, getting told something like that is a little like, what do you do with that, right? Because that's that's like naming it right there, right? So what do you do with that? Cassie, I really like that idea about, you know, about what you just said about really staying there a little longer. You know, my take was, well, I hope that's not what it's about. Maybe you need to see your own doctor. Right. But you know, if your patient is brave enough to bring that to the conversation, you should at least be brave enough to stay there. So I like that. I like that very much.
Yeah, we may get whisked out of this because Kate has to jump off to the round tables, but I think there's a way to continue some of the conversation in the Whova app on one of the conversation. But we certainly, you know, we found this to be very difficult, but we think it's very important work. And it's going to just require continued collaboration in developing the cases and working with the SPs and identifying assessment tools and creating safe spaces for students to practice, because a lot of these are really communication skills. It really goes back to me to giving bad news. Some of the teaching I've had around how to give bad news as a cancer doctor, sort of ask, tell, ask, those kinds of things, or naming the emotion, or grounding the patient, those kinds of things.
Yeah, real quickly, what I was impressed with what some of what you shared was some of the kind of the communication skills, patient-centered communication skills we already do, right? That you don't necessarily have to create something new. You can add, but that what we're already teaching in terms of patient-centered communication skills may apply in this area. So that was great to hear. All right, thank you, Elise. Thank you, everyone, for participating. It was very helpful and really great. Thank you.
Thanks,
Thank you.
everyone. Thank you, Helen. Helen did
Thank
a
you
lot
so
of this
much.
good work.
Helen.
And
Thank you so much, everyone, for
Good
helping
job.
us kind of develop these cases further.
Thank you,
you.
Wanda, for
You're welcome.
collaborating.
Wanda, go
Excellent.
enjoy. Wanda's in Key West, everybody.